So we are here in the state kicking off legislative session. It began last week, and the governor has appointed a new ADHS director, Dr. Teresa Cullen, who is beginning to transition into her role here at the state. We're looking forward to welcoming her, and for those of you that have not worked with her yet, she is excellent, coming to us from Southern Arizona, and we look forward to introducing her to EMS Council in the future, I'm sure. In terms of legislative session, ADHS is not sponsoring any bills this year, but we do remain available if any folks have questions about bills that are EMS or trauma related as we move through session. We just want to make sure that people know the Bureau continues to be a resource. The department is working on rule reviews by statute. We have to do a rule review every 5 years, and so we are looking at our rules that are due for that 5-year review, and the department is actually seeking permission through Title 41, after we've done all of our 5-year reviews, to potentially update, as you all know, ground ambulance rules. That's been ongoing, EMCT certification and training rules, and potentially trauma rules. If we receive approval to move forward with these rule updates, you can expect that any rule updates would follow all of our statutory requirements. Some of them would be very limited in nature because we would only have to update some very minor things to make the rules a little more clear and concise following statute and rules. And as a next step, you can expect that we will keep all of our stakeholders informed, and any drafts that we do post would have a public comment period. So of course, we will keep you all informed and hope that you all will participate in that public comment period. With respect to EMCT certification and training rules, we do hope that through that process, we will be able to establish a critical care paramedic pathway. That rule update would definitely require that we form a work group in the future, and so certainly more to come on that as we learn if we have received approval to be working on EMCT certification and training rules formally. It is a slow process, but please stay engaged. Two things that I would like to plug before we move through the rest of our agenda. We are working on a regional and statewide needs assessment. A needs assessment survey link will be going out later this month. We are also getting ready to launch a new EMS and trauma portal, and that's an exciting one for us. It will replace our current EMS portal this spring. I think we have a couple screenshots to share with you later in the agenda, but I just want to plug that now so everyone knows that those are some important projects we are working towards here at the department in 2023. The final thing I'll say is big thank you to folks that participated in our base hospital and medical direction seminar in the last week. We're glad that we've been able to revive workshops and begin to meet again in person, and also offer that hybrid model for people to join across the state. We're looking for feedback from participants, all of our EMS providers and base hospitals and medical directors, so that we can plan future events. We're hoping that we can incorporate topics that are important and relevant to the community so that we can make these future events that much better going forward, and just appreciate everybody that was involved in starting those workshops up again. So I think we got a good agenda here today. We'll go pretty quickly through the rest of the Bureau report. Everybody that's on, please help us share updates quickly. I want to introduce some new Bureau staff that are in the room. To my right, we have Brian Hubble, CON and Rates Manager. Next to him, Jeff Kerr, our Compliance and Enforcement Manager. And we also have Sebastian, who has just joined the Bureau, and he is going to be part of our FR CARA grant, working on first responders and getting the lock zone out to folks through that first responders grant. So thank you, welcome again. Julia, can we go to you quickly next?
Yes, just a couple of quick updates. So for SHARE, the Arizona Emergency Medicine Research Center continues to collect and clean hospital and EMS data from 2022. So thank you so much for working on getting that data in. Updated cardiac receiving and referral center lists are posted on the Bureau's webpage. Most recently, the Bureau recognized 2 new referral centers, Oro Valley Hospital and Honor Health Star Crossing. And then the SHARE team is also looking into the possibility of hosting some in-person meetings in coming months. If you or your agency would be interested in learning more about the SHARE program, how to utilize SHARE reports, etc., then please let us know. So, anything else to add, Jill?
Nope, that was a great summary. Thank you, Julia. Next, I'm going to turn it over to Ann Vosspring for NEMSIS 3.5 update. Ann?
Good morning, everybody. Just a few things and just a little bit of an update. So just a reminder, again, I'll say this every single time. EMS agencies should transition to the new version 3.5 before July 1st, 2023, which I can't believe we're already in 2023. So it's coming up soon. It's going to sneak up on us. So if they don't have plans in the work, it would be great if they start looking at that. And of course, if they have questions, they can reach out. We have 3 agencies actively submitting 3.5 for several months. Several more are in testing or have contacted me that they have timelines in the very near future to start submitting. We are currently updating our 3.5 validation rules right now based on agency field feedback. So we had our first version out there. So the 3.5 schematron, there's a new one coming out soon. Kind of exciting news, at least I think so. All existing EPCR vendors currently active in Arizona and reporting to AD peers have achieved NEMSIS 3.5 compliance, which is great because that's one of the first steps in making sure that the data is going to exchange properly. And always just keep looking for materials on our 3.5 resources tab. I keep adding them. If you're an EMS agency, please make sure that you are getting emails so that you know your contacts are up to date and that you have them for updates on 3.5 and other things. And just lastly, a plug for 3.4. Data closing for NEMSIS is coming up in about 3-4 weeks. And so we're trying to get any missing 2022 data submitted to us prior to that so that it can be included in the national data set. Thank you.
Thank you, Ann. Any questions for Ann regarding the transition to NEMSIS 3.5? I think, fortunately, we don't go through these transitions too frequently, but it is a big deal because the data will not process after July 1st. So if you have not contacted Ann or your vendor, if you have any questions, she is by far I think not just state expert, but really the national expert. Many other states reach out to her for expertise. So please reach out to her if you have any questions about that. Next, TJ, are you on the line for National Registry update?
I am. Good morning. Just a few items. The National Registry is continuing with their BLS practice analysis, getting ready to start working on their redesign that goes along with the ALS redesign that's ongoing. They're beginning to incorporate some of those changes in the near future with a plan to go forward completely at the late 2024, early 2025 region. The one change that has taken place as of January 1st, they increased their fees for initial testing. Most of these are pretty minimal. The EMR one is, I think, $3. EMT is $6. And most expensive is the paramedic one that went up $8 as of January 1st. One of the things that I would throw out there, since they permanently waived their distributive education limit, I think I've seen probably close to 20 new continuing education providers are out, all claiming to meet various standards. So I would suggest that everyone trust but verify, make sure that the organizations that might be providing services to your employees or your students are actually providing the services that they claim to be, and make sure that they are actually accredited where they need to be by the various agencies that they're claiming association affiliation. And that's about all I've got. Thank you.
All right. Thank you, TJ. Next, if we can click on the 911 call volume data visualization dashboard. For those of you who were not on our first staff meeting, we had a really nice fall presentation, and it was kind of nice to see an external stakeholder really trying to highlight some of the work that Vosspring and her team have done. For anyone who's not seen that, if we can click on the dashboard there, really impressive to see the amount of work that has gone into producing this, and for us to really be able to have real-time data that is available. So you can see here the 911 call volume that's reported to AD peers. So it's the call volume by week, and then it gives the daily call volume, and then we have kind of specific areas of interest. You can see here cardiac arrest, ST elevation, MI, stroke, falls, and motor vehicle crashes. One of the things the fall prevention group mentioned was that it seems as if every week we are over 1,000 falls consistently. You can see this past week, 1171. It's really consistent with that. So wonderful work from Russell and her team, and really want to highlight kind of how amazing this is, that this is out there and available. So, yeah.
So the bottom section, is that based on a linkage with the paramedic, with the EMS chart, or is it based on what's mentioned on the 911 call?
So this is based on the chart. So this is ADPS data.
All right. So the top is then the volume of calls to 911 centers, and then the bottom is a breakdown by paramedic profession.
Yes, great question. So the top is actually 911 call volume that goes to ADPS. So we don't have access to, we have a very, very large majority of EMS agencies that report data to ADPS. I think there's maybe a few small ones left in the state that do not, but we don't have access to all 911 calls. We have access to the data that's reported to ADPS. So thank you for clarifying that. That is an important clarification. So one of the things we were able to track, especially during 2020 when we looked at kind of call volume, we did, even though it wasn't necessarily 911 call activation, we could look at our ADPS data and see big reductions in call volumes when we had our first two kind of the main lockdown and then first surge for COVID. And that data really correlated very well with what we are seeing out there in the community. So while we don't have the actual 911 data, it does seem to correlate quite well. Next, if we can go to the EMS annual report and specifically to the snapshot. This is a draft format. We will make sure that we get the final version out to everyone here in the next, hopefully, few weeks. Just going to highlight on the snapshot here, just for clarification, it's always something I have to remind myself when we look at this data. This is our 2022 report that is looking at 2021 data. Anytime we have to link to other data sets, such as hospital discharge data set, there is a lag time when we get that data, and so that's why this report is a little bit further out time frame wise. You can see for 2021, for total EMS incidents reported, there was over 1,231,000 cases, and included in the analysis was just over 1.1 million cases, or just over 1.1 million cases. We have our EMCT certification numbers at the top right there. You can see in 2021 we had 21,773 EMCTs and just under 2,500 new EMCT certifications completed. So for our team that does these renewal applications and initials, they have a huge volume that they are going through on a regular basis. For EMS agencies that reported for 2021, a total of 179 EMS agencies reported to data to ADPS. That number has gone up since then, and you can see the breakdown between ground and air providers. If you can scroll down just a little bit further, we've got the breakdown of 911 calls to interfacility, and then one request that was asked was to include some pediatric-specific categories of interest, and you can see that in the middle of the snapshot there. Some telling things when you evaluate this is injury. For those who are present on the staff report, we had a great presentation regarding ATV accidents in pediatric patients, and certainly we can see injury as a large percentage of pediatric 911 calls. Respiratory distress also quite a significant number, 8.6%. Seizures, 6.4%. That will contrast a little further in the snapshot when you compare that to kind of all adult data and peds combined. And then we have the combination of psychiatric disorders, suicide attempts, or thoughts, and then substance abuse listed as well. On the right, you can see with the map of Arizona, so county-specific EMS incident rates per 100,000 residents. You can certainly see that portions of Arizona are affected much more than others. Specifically, we see a very high rate of calls per residents in La Paz County. And then median time intervals, again, this is for statewide data, so this is going to include all different types of geographic areas as well as jurisdictions. But we see response time 8 minutes, scene time 12 minutes, and transport time 11 minutes. But again, this is statewide for the entire state. When we look at prevalence of primary and secondary impression categories of interest, you can see here again with all age groups, injury is still a very significant percentage of calls at 14.5%. Substance use, psychiatric disorders combining for just around 7% of calls. Seizures, I think this is interesting when you compare kind of all age groups. For all age groups, 2.1%, but a little over 6% for pediatric patients. So recognizing that in pediatric patient population, this is a more frequent reason for 911 activation, and then our cardiac arrest numbers as well. When we look at mortality at the bottom by primary and secondary oppression, I think no surprise that mortality rate is still pretty high with cardiac arrest. We definitely saw kind of with the pandemic an increase in our cardiac arrest mortality, which has really been matched by national data and felt to be multifactorial. So we'll be interested to see if that trend continues or if it starts normalizing to previous data as we move out of the pandemic. Opioid-related mortality at 13%, STEMI at 8%, stroke 5.5%, and diabetes 2.5%. So again, we will have this produced in its final format, make sure it goes out to all the statutory committees once it is completed, but just wanted to highlight some of the key pieces of the report that's put together. Moving forward, the STAB annual report is something that is required in statute, so we will always continue with that. That is also great data linkage between our state trauma registry data as well as our AD peers data. But we really like to highlight with a lot of the work Bob and her team have done moving forward, we may be kind of transitioning away from a formal PDF type annual report for EMS and going towards the real-time 911 dashboard as well as all of the other Tableau dashboards. If anyone needs any help is looking for data, there is a ton of information that is available on our website under EMS data, and really we cover this and it's a much more real-time effect. So moving forward, I think that will be the move. So wanted to bring that up for the committee and just get some feedback on that. Any questions regarding the annual report snapshot or kind of the transition to more of an electronic version moving forward?
Just a comment that Vassal and the team are remarkable. It's really cool to see what they're able to do, not just in terms of this report, but the real-time dashboards are just remarkable, and look forward to seeing what we're able to do with that data moving forward. Good job, Vassal.
Yes. All right. Hearing no further questions, we will go ahead and move to our Standing Committee and Regional Council reports. Do we have a TEPI report, Shelley, or will you be giving that one?
Well, Rebecca Harrow's off the hook now, isn't she? Thank you to Rebecca for all of her time and efforts doing the liaison report. And this is also a time to plug, there is a vacancy if any of the EMS Council members would like to do a TEPI liaison role, please let me know. I do have draft TEPI minutes. I can go through the action items, if that's okay. At the last TEPI meeting in November, they approved their July minutes. They also had Vatsal present an ad hoc report for ground level falls with hip fractures. They looked at those numbers. We also looked at the 911 call volume dashboard, also seen here. Kate Garcia shared the new 911 call volume dashboard. She welcomed any feedback. We've also got projects with trauma data. We're taking ideas for that. Bruce Barnhart gave a wonderful comprehensive presentation on the SHARE project program. And then looks like they talked about trauma registry needs and providers. And they tabled a discussion on the ASTR public data set age groups. End of report.
Very much, Shelley. Next, Brian, for education reports.
Thank you, Dr. Bradley. Good morning, everyone. Can you hear me okay? I'm using equipment that I haven't used in 3 years, so.
You're loud and clear, Brian. Thank you.
Thank you. So Education Committee also met on November 17th. We had approved a training for the new national guideline for EMS field triage of injured patients, and that training was approved as presented. There is training developed for providers to educate on pre-hospital death notification. That was approved with a few edits for clarity. There was training that was approved for SPR for EMT airway, and that was to include CPAP. That training was approved with a few minor edits also. We have a schedule of review for training modules. And one of those that came up was what should go in your EPCR. And there was a work group that was approved to review that training module. So there was a discussion on seeking stakeholder input on critical care certification and community paramedic certification. And that was the end of our agenda.
All right, thank you, Brian. Next, can you give the PMD report, please?
Yes, we have a standing item that was put on the agenda recently to discuss medical direction for hospital-based paramedic practice. There was no discussion on that topic at this meeting. There was a request to make diltiazem on table 1, the EMCT drug box list, to be required rather than approved. There was no motion that was moved to do so. There was a request to do drug profiles for ibuprofen and acetaminophen. That was as a result of the addition of over-the-counter medications for pain relief and I think fever also. And I volunteered to do that, and those have been submitted for our next meeting. There was a request to add to table 3 special agents eligible for administration and monitoring for paramedics in the hospital setting to include PO narcotics, hydromorphone, haloperidol, droperidol, metoclopramide, antiemetics, vasopressors, narcotic drips, propofol, Precedex. And with the result of that was there was a motion to form a work group to look at that in the future. And so that was approved. There was a request to show dexamethasone 8 milligrams or solumedrol 125 milligrams on one line for EMT I-99s and paramedics. And that there was an amended motion to approve that. That will be going to MDC this afternoon. Then there was a separate line also for methylprednisolone sodium succinate that would be removed as a result of putting both of those together in the same section. There was discussion to remove sodium succinate from methylprednisolone as a result of the previous action. Dr. Castro Marin withdrew that as an action item. There was a request to look at adding as an STR skill for EMTs the use of intraosseous placement. And there was some discussion that occurred on that, and that action item was withdrawn also. There was discussion about the way our triage treatment and triage treatment guidelines are going right now. It's taken a long time to get through them. At every meeting, we have other topics for discussion also. And so there was a request to look at doing an all-day meeting to complete the entire set. And the last agenda item was to look at some of those treatment guidelines. And so those items were tabled to move forward to the all-day meeting, which I believe is scheduled for February 16th at this point in time. And that was the end of our agenda. Thank you.
All right, thank you, Brian. Next up for regional council reports, first Roy for the Ames report.
Thank you, Dr. Bradley. Shelley, I don't know if the written report went out to everyone. If it did, I don't need to say anything. If it didn't, I can briefly recap it.
I did attach it to the calendar invite, and I do have it displayed.
Okay, great. Then I don't really have anything to add on that. I do want to point out we did a number of elections and re-elections to the board. And not the least of which is the esteemed Dr. Garth Gama was reelected as chair of AIMS. Point out that we have our 23rd annual EMS Odyssey Conference will be held on June 8th, 2023 via Zoom. We've got a very strong and well-vetted group of presenters, and hopefully that will be as successful as our third annual EMS CE Fall Forum, which had 157 participants, and we awarded up to 7 CE hours to those that qualified and spent their time. So those are just a few highlights. We're real busy right now with coordinating the hand-heavy instructor training. That's going to occur on January 20th, 2023. The Central Area we selected 12 Central Arizona regional participants serving rural areas, and they are expected to conduct at least one training session in their area by June 30, 2023. And I'll answer any questions. Otherwise, end of my report.
Thank you, Roy. Next up, Sarah for a SANS report.
Good morning. Thank you, Dr. Bradley. Recently, on the 17th of January, we held our annual meeting. As such, it was quite a long meeting, so I won't go through every detail of the notes, but I will say that Dr. Gaither was reappointed as the chair for another 2-year term. We have many projects and goals for the coming year and are looking forward to a successful year, and we appreciate the Bureau's support in ensuring we can meet those goals. I can take any questions.
All right, thank you, Sarah. Next, Vince, for the names report.
Good morning. NAMES had a general meeting on November 4th, and we had a special agenda meeting on December 22nd. I've submitted the NAMES report if anyone would like to read the details of our meetings. But we really only have one announcement. Reminder that NAMES is presenting the 14th Annual Pediatric Symposium on March 6th and 7th in Flagstaff at Little America. And we welcome you all to participate in this awesome pediatric educational opportunity and to come play in the snow. We have a lot of it. Please feel free to take a lot of it back home with you. And we invite you to go to our new NAMES website and register for the symposium and to see what NAMES is offering. Our next NAMES meeting will be scheduled for February 3rd, and that's all I have to report. Thank you.
Thank you, Vince. Next up, Rod, for WACM's report.
Yes, ma'am. We had our meeting earlier this month, January 11th in Parker. We've been working hard on the provider assistance award, almost through with those for the year, which is good because we are diving straight into the EMCT education, and the executive board of WACM's meeting. We've got to meet a couple more times to kind of iron out how this whole thing is going to work. It's it's uncharted waters for most of us here in the state. So we really appreciate the opportunity to do that. And our next meeting is May 11th in Lake Havasu City. Any questions for me? Thank you.
Thank you, Rod. Next up, Dr. Woolrich for a PACES update.
Yes, thank you. Good morning, everybody. I guess it is still morning. For the PACES meeting, we had our last meeting in November. It's an open meeting. I would encourage anybody who's interested in attending, please do so. It's at 1:30 following the PM meeting. In the last meeting, we discussed that there was no vacancies. We had just recently appointed Chris Ramos as co-chair to work alongside both Adam and myself in management of the Pediatric Advisory Committee. In that last meeting, our primary focus on the agenda was to look at some of the work groups that we had had. We had a behavioral health subcommittee work group that has now sundowned as we've been able to make additions and communicate those to the Education Committee. We've also identified a seizure educational module component that is coming to conclusion and will be up for the Education Committee agenda in the next meeting. Also discussed in November was the EMSC State Partnership Grant that is cycling. New to this grant is the development of a pediatric recognition program for EMS agencies. This will be new, and we're establishing a work group to start brainstorming that to develop it. As a component of this grant, it would be to look at certain elements to be able to designate pediatric focuses within those EMS agencies. As background information, many of you know that the EMSC State Partnership Grant not only designates the establishment of PACES Advisory Committee, encourages EDs to have a pediatric designation status of what we currently do in conjunction with the work with the Arizona chapter of the American Academy of Pediatrics. But this will be a new component, essentially being outreach towards individual EMS agencies and creating maybe a template or structure for that. Fortunately, we'll be creating this de novo. There was a specialized project that came out of Kentucky that was HRSA funded on this topic, so it would serve as a template for something we can adopt going forward. So again, encouraging participation and volunteers who would like to be involved with that, and hopefully be able to join us at our next PACES meeting. And Adam, if you're in the meeting, do I have anything you want to add, sir?
No, but thank you. You covered it well. Appreciate it. We'll take any questions.
Okay. Thanks, everybody.
All right, thank you, Dr. Woolrich and Adam, for the update. Next, we will move to our discussion and action items. So we're having some audio issues, so just come off mute when the train had gone by earlier. So if I can get a motion to discuss, amend, and approve the EMS Council minutes from September 15th, 2022, please.
So moved.
Brian.
Hayden.
I have Brian for first, and the second, who is that on the phone?
Jim Hayden.
Thank you, Jim. All right, we'll scroll through the meeting minutes. Any recommended amendments to the minutes? Hearing none, any opposed to the meeting minutes as presented, please say nay. Any abstentions? All those in favor say aye.
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 Aye. Aye.
All right, thank you. Next, we're going to move on to the EMS and Trauma Online Portal. I think there's a item for you to bring up if you can, Shelley, the next agenda item.
Yep, give me a sec.
Thank you.
Refreshing my feed.
Shelley, thank you so much. While you're pulling that up, I think we can't say enough that we want folks to know that there is a new EMS and trauma portal that is coming this spring. We're hoping to bring it online as early as March, but it could potentially be a little bit later. We have a couple screenshots to share with you in preparation for the portal going live in spring. And it is an image trend portal. It will replace, thank you so much, Shelley. It will replace our current portal that you all are very familiar with at ems.acdhs.gov. Here you can see the login page. not too much of a deviation from how we currently log into the portal. But if somebody were to put their login credentials here when the system does go live, there are going to be a number of new features that are available within the portal. If you can go to the next screenshot, we only have 2 screenshots to share today, but the accounts and the services that will be available within the portal will be for, of course, EMCP certification. This is where you will go to renew your certification or apply for a new certification. We will also have features available for ambulance services, for registration and licensing, and some even special services for our trauma centers and base hospitals. So we're really looking forward to being able to explore this with all of the stakeholders. We're going to start working closely with the regional councils in the next month to share some updated screenshots of how to log in and how folks will be able to access the different features and applications within the portal. It's a really exciting time. We will be able to get better metrics on our EMCP workforce data, and we will be able to get new metrics and things that will help drive decision-making moving forward across the board. So I will pause there and just ask if there are any questions about the new online portal. And thank you in advance to our regional councils for helping us to amplify this messaging. All right, well, I'm going to hear silence as a good thing, that there are no questions at this time. We will look forward to sharing some updated info, again, on how to log in and use all the new features in the portal. Thank you.
All right, thank you, Chief Garcia. Next, we wanted to spend a little bit more time just talking about the FR-CARE grant. As mentioned previously, we are very excited that we have Sebastian here in the room who's kind of being able to dedicate all of his time to the FR-CARE grant moving forward and really helping to build an naloxone Leave Behind program across the state. You can see here on our current website what we have available. We do have the training PowerPoint in both PowerPoint and PDF version. We have some kind of draft or some educational resource modules, as well as an naloxone Leave Behind letter. Moving forward, the goal with the grant program, as mentioned, will be to have a training platform that can be uploaded into a learning management system, or that individuals can just log in directly to the link. We did have this transition when we ended the first grant for law enforcement personnel or EMTs. They can currently log into the online training, get their training certificate from that. So the goal moving forward will be to develop that. That will be in place as well for any EMS agency that would like to implement this. In addition, we will be ordering the naloxone directly through us, and we'll get it shipped directly to your agency for distribution. So our hope is that within the next 2 to 3 months, we should really have a good update for everyone at the next EMS Council meeting in May. But this should be something that really can help take off this program statewide. So I'm happy to open up to any questions that people may have in this regard.
We'll have like the Oprah slide with I
think that's in the presentation somewhere, yes.
It is in the presentation.
That is in there, but you know, we've been very fortunate. The ADHS has been providing a number of EMS agencies with naloxone for a number of years. With this transition, as agencies start to become part of the naloxone Leave Behind program, they will be able to get that directly through our current grant. All right, so next item is to discuss the national guideline for EMS triage injured patients training. So for those of you who are not on the staff meeting, this is a pretty substantial change. The American College of Surgeons had last updated their field triage guideline in 2011. That was formally endorsed by staff at that time. Anyone who has been involved in these committees or EMS in Arizona likely got one of the kind of laminated pocket guides that the Bureau sponsored. I found a couple of those in my office from 2011 that went out to kind of stakeholders. But really, we recognize this is a substantial update moving forward. And so we had asked our education committee to put together a training presentation. So a really big thank you to Drs. Munn and Rice from University of Arizona. They kind of took the what the education committee had put together and then created a platform which can be uploaded to a learning management system that has audio files. It's kind of a timed presentation, so you can't just hit play and walk away. You have to actually engage, answer questions, listen to audio to be able to get to the next step, and really gets into a lot of the detailed updates to this training. We wanted to make sure we spent a few minutes just updating kind of why and how this changed. Having seen the presentation from ACS at the NASEMSA meeting last summer, they are really trying to make sure that they publicize this as much as possible. They did a number of systematic reviews. These were the 5 big reviews that they looked at when they went to evaluate the update. They published a number of articles with evidence-based guidelines based on how they made these changes. So we've included that in some of the training as well. If we can go to the next slide, please. This is, again, the old 2011 version. Next slide. This is the algorithm. If we can scroll through, I think the next 2 and 3 just talks about kind of how you would actually implement this, how you look at your flow of information. And again, kind of looking at your injury pattern as rapid visual markers and your mental status and vital sign as your physiologic markers. Keep scrolling, please. As we move down, we kind of go from the red to the yellow criteria, which is mechanism of injury and EMS judgment. Next slide, please. We'll kind of go into each of these in a little bit more depth, so we can go to the next slide. You'll see here the injury pattern. There are some clarified items as well as a new item. For those of you who have been around with EMS, you recognize back in 2011, EMS did not have tourniquets or wound packing ability. This has now become part of normal scope of practice. And so this has been added into the ACS field triage guidelines. Next slide. There's some also clarifications that they've added as well regarding some of the injury patterns. Next slide. And then next one down, some big changes really, and this is, I think, where there's been some opportunities for education for EMS, is looking at some age-specific criteria, so specific to both pediatric and geriatric patients. So you can see here that there's some very specific items regarding pediatric patients as well as geriatric patients greater than 65. Next slide. One of the most substantial changes, and this is described in the audio part of the training, is looking at transitioning from a full GCS score to a simplified motor-only GCS score. And so this is going to be something that will be quite a bit of training, but I think will be much easier for EMS once they get comfortable. I see that Ann is sending me an update to that. So I mentioned at the last meeting that one of the difficulties is that EPCR vendors are still currently requiring a full GCS score. But as we transition to this training, we really want EMS providers to focus on just kind of the motor score. So I'm just looking to see what Ann is saying. NEMSIS is working on a critical patch, which should come into place in 2023, which will help align with this update. So that was one of the things as NEMSIS did their NEMS 3.5 update, that overlapped at the same time that ACS was doing their updates to the field triage guideline. So NEMSIS and ACS have been working together to align that. So that will hopefully be a fix for EMS agencies in the next few months as well. Thank you for that update, Ann. Keep scrolling. You can see we've got pediatric motor changes, motor score as well. And if we can scroll down a little bit further, one of the other big changes is mentioning looking at kind of a modified shock index for trauma patients, especially when we look at geriatric patients. And so there is some training included in the audio files as well for that. Next slide. So the mechanism of injury, if you go just slightly further, you can see here there's some significant clarifications that have been included. Right here you see very specifically that extrication relates to entrapment, not simple confinement. So recognizing that true extrication does correlate with likely significant injury versus some of the other findings. And then you can see some other significant changes as fall greater than 10 feet for all age groups. I'm sure most people recognize that historically this was always for adult patients, falls greater than 20 feet, and for pediatric patients greater than 3 times the height of the child. So these are some of the other updates there. And I think I listed above, one of the other things that was, I think, a little higher up as well was pediatric patients specifically added in. For pediatric patients not properly restrained with a child car seat or booster seat, that is one of your indications as well, recognizing that this is associated with significant injuries in the pediatric patient population. The other area that will need quite a bit of training for EMS providers is EMS judgment sections. And so one of the pieces with this is looking at some of the changes. The first area, and they had quite a bit of data to support these updates, was looking at low-level falls, so children less than 5 or older adults greater than 65 with significant head impact. So recognizing that that is something that would fall into the EMS judgment category. They also separated out the anticoagulation use. So this is not only associated with head injury, but recognizing someone who's on an anticoagulant that's involved in other type of trauma, whether ATV crash, whether vehicle crash, they were at risk for other injuries based on their anticoagulation use. And then if you look at suspicion of child abuse, this is the new criteria and the rationale from ACS about why they've included this as well, recognizing that one isolated fracture with respect to child abuse is often associated with several other injuries that may not be readily identifiable to the EMS provider. And so this is one of the things to consider when you're determining where to take a patient. Trauma centers are required to have resources to evaluate pediatric patients for potential neglect and abuse. Scroll down a little bit further, so special high resource healthcare needs. This is something that I had to kind of read to understand what were they actually referring to, and what they're looking at is kind of comorbidities, understanding that elderly patients that have a number of comorbidities, such as patients who have a ventilator dependence or ventricular assist device, may require higher resources than are readily available for other facilities. Next slide. Some modified criteria, low-level falls. Again, they included some data on this, recognizing that some of the data wasn't necessarily the best data available, but why they included that. Next slide. And then again, anticoagulation use, just recognizing that some of this does fall under what we term EMS judgment, and the training then moves into some example cases, recognizing that not every ground level fall on anticoagulation needs to go to a trauma center, but understanding if you've got someone with a depressed GCS on anticoagulation, or they've got a head injury with a large laceration that's bleeding profusely, or potentially a head injury with signs of trauma, and then a secondary injury such as a hip fracture, that those combined injuries likely would indicate a need to go to a trauma center. So again, these are kind of clarified in the examples. We don't need to go through all of these, but we wanted to spend some time for EMS Council, recognizing this is a really big, substantial change. As this transition occurs, the trauma centers are probably all looking at their own activation criteria as well. Some trauma centers have been making changes over the last few years. I did want to spend some time going over this with the group. We will work on making sure we currently have the PowerPoint and PDF version uploaded to our website. I have been working with Dr. Zaman and Rice to kind of figure out how to send the learning management system option. I think we have figured it out, so as long as we get that ironed out, we will hopefully get that out, sent out to everyone here shortly. Any questions about the training or the updates?
This is super. Thank you, Dr. Bradley.
Thank you, Jim. All right, hearing no further comments, I will turn it over to, I think, Chief Garcia, are you covering the regional needs assessment?
Yes. So one more time, for anybody that has not heard yet, we are working on getting a link out to a regional and statewide EMS and trauma needs assessment. We are going to, of course, ask all of the regional councils to help us get this link out to everybody. We hope that everyone will participate in the survey, because it's really for us to be able to get more information on workforce training needs and priorities, as well as any other resource needs across the state. It's so important to get the feedback from everyone, because this is going to help inform our state EMS and trauma strategic plan and potentially future funding requests. So thank you in advance for everyone. Looking forward to that link. And I will pause and just ask Julia, do you have any additional updates on survey delivery or anything like that?
No, we're currently working on getting the questions uploaded into an online platform and hope to do some testing with that over the next couple of weeks. And then we'll be in touch, as Rachel mentioned, hopefully at the end of this month or early February.
Thank you. All right. Thank you very much. Next, we have an action item that we typically do need to have an update to our bylaws every 3 years. Shelley keeps us on task with that. So if I can get a motion to discuss, amend, and approve forming a work group to review our bylaws.
Brian, so moved.
Thank you, Brian. Can I get a second, please?
Royal, second.
All right. Is there anyone that is interested in sitting on the work group?
Brian will volunteer.
Thank you, Brian. I had a feeling I could count on you for that. Shelley does make this very painless. It's usually a one meeting endeavor, so. Shelley. Well, I think technically I actually need to take an approval that we form the work group, so I'll take a vote on that. And then if anyone is interested in joining, you can contact Shelley Bissell. So anyone opposed to forming a work group, please say nay. Any abstentions? All those in favor say aye.
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 Thank you. Are there any more volunteers to serve on that work group?
This is Roy. I'll volunteer depending on when the meetings are going to be.
Thank you, Roy. All right.
This is
We have-
Vince.
Thank
Vince
you,
Martinez will volunteer for this group also.
Excellent. All right. So we have at least 3 members, and again, anyone else who would like to volunteer, please email Shelley, and we can make sure we get you added to that group. Next on the agenda is any agenda items to be considered for the next meeting. Are there any topics this group would like to have covered or brought forward? As Chief Garcia mentioned, we are hoping that our new portal will have gone live by then, so we should have a good update regarding that, along with the update regarding EPR with some more information moving forward. A reminder, I did put in the chat, we will need an EMS council rep for TEPI, so if you're interested in that position, please let Shelley Bissell know so we can put your name in for consideration as well. I will open up next for a call to the public. Hearing none, we have a summary of current events that are in your agenda packet as well as displayed on the screen here. Some of these are coming up here in the next month or so please look out for those if you know anyone that is looking for some education or opportunities. We also have the Bureau's website for additional information as well. Our next meeting will be May 18th, 2023 at 10:30 a.m. If I can get a motion to adjourn, please.
So motion.
I'll second.
Oh, sorry, there is a question in the chat. Let me look at that, bring that up quickly. The question is, I was wondering if the state is considering creating a first EMR program. I help provide educational opportunities to several that could benefit from additional staffing for their combination of volunteer departments.
Yeah, thank you for that question. In statute, we do have requirements related to EMR programs. And so there certainly is an opportunity if we get approval to update our rules to clarify EMR certification and training requirements. And we will look forward to finding out what our next steps are so that we can then engage folks in a work group for those things. So thank you for your comment and your interest. We'll definitely be reaching back.
Thank you for bringing that forward. Any other questions or public comments before we adjourn? Hearing none, meeting is adjourned. Thank you very much.